50 of them are on our new material that I covered. So there's going to be, 10 from AKI, 10 from the first CKD, 10 from the second CKD, 10 on the dialysis lecture next week, and 10 on gout. So most of it is new material. We did throw in some old material. Just the theory behind it is that hopefully by reviewing it, you're going to remember it on rotations that much better, because a lot of people go on rotation and go, oh my gosh, I don't know how to do a paper communion and things like that. So there will be 10 questions of old material. This will not be Dr. Manitou's questions, and it will not be Dr. Dr. B's questions. There's going to be a couple of questions from each of Dr. Wheeler's lectures, and then I'm going to have 2 questions on classification and renal function. So kind of what to expect for that. And so for today, we're going to be talking about the secondary complications of CKD. On Wednesday, we talked about how to identify CKD and prevent its progression. Now we're going to focus on those unfortunate patients who do have advanced CKD and some of the crazy things that happen to their bodies. I also have a guest lecturer for you today. This is Dr. Stephen Lemieux up front here. He is a UConn alum, class of, 2014. So he's been in your shoes not that long ago. And now he is a PGY2 critical care resident at Yale New Hospital. So I'm going to spend the first chunk of lecture talking about anemia associated with chronic kidney disease. And then the second half of that, I'll turn it over to Dr. Lemieux, who's going to talk about, remind me of one day. The crazy things that can happen to your bones when you have advanced chronic kidney disease. And then just as a plug for next week, on Wednesday, I'm going to have another guest lecturer from Yale New Hospital come in. I'm going to have the dialysis pharmacist, Jim Sargianis, come in and talk about how to dose drugs in dialysis. And those of you that spent some time at Yale know that he's a very inspirational person, a fantastic speaker who cares a lot about his dialysis patients. So it's going to be really fun. All right, so getting used to my really long objectives here. Really, when you're thinking about studying for the exam, think about if you had a patient with anemia secondary to CKD, or you had a patient with bone disorder secondary to CKD, how would you come up with a therapeutic plan for that patient? So be sure to be familiar with what medications you would want to give to that patient, what your goals for that patient would be, and how you would counsel the patient on those medications. So I'm trying to make my objectives in line with what you would really do in clinical practice. So just think about a particular patient and what you would do for them with those 2 conditions. All right, so I feel like I've been yammering on about the kidneys for quite some time now, so I wanted to bring us all back to the beginning again, so you can reorient yourselves to all of the magical things that the kidney can do. So with Dr. Wheeler, remember that he talked about how kidneys can affect potassium balance. The kidneys are responsible for excreting potassium, which is essential for cardiac activity. And if you get too much potassium in your blood, you can have arrhythmias that can kill you. With Dr. Wheeler, you also talked about how the kidneys are responsible for producing bicarb to help regulate blood acidity. And so when patients lose some of their kidney function, they can get a metabolic acidosis because their kidneys are no longer able to make bicarb. And then finally, with Dr. Wheeler, you also talked about a lot of sodium and water disorders that can occur when a patient has kidney issues. Remember that the kidneys are responsible for concentrating your urine or diluting your urine. And so patients with kidney dysfunction can become very fluid overloaded if they stop making urine altogether. In the quantification of renal function lecture, we talked about how the kidney can remove waste products. And of course, even more importantly, from our perspective, we talked about how the kidney can remove drugs through filtration, secretion, and reabsorption. Then today, we're going to round out the rest of these functions. I'm going to talk about how the kidney is responsible for producing erythropoietin, which is a hormone that stimulates red blood cell production. We'll talk about the severe anemia that can occur. And then Dr. Lemieux is going to talk about how the kidney is responsible for maintaining your calcium balance and actually is responsible for activating vitamin D in your body. So when you have advanced kidney disease, some crazy things can happen to your bone structure as you lose the ability to hang on to your calcium. This CKD stage chart is going to start looking familiar to you guys because it comes up again and again. Remember that you don't have to memorize the numbers, but just remember you're considered to have kind of a moderate CKD when your GFR falls below 60, and you're set up for kidney failure that would require dialysis when your GFR falls below 15. The thing that I've added to this particular CKD table now is the metabolic consequences that you might expect at each stage. So remember how the kidney is that silent killer that lurks for you in the elevator and you don't know you have kidney disease until it's too late? That is true. You won't see many symptoms of CKD in the early stages. And even around stage 2, when your parathyroid hormone level begins to rise, you're not going to feel that either. We often don't catch some of these changes that occur with CKD until CKD stage 3 or 4. That's when you start seeing calcium issues and anemias. Calcium issues and anemias. And then the stage 4 CKD, you'll start seeing metabolic acidosis and patients tending to develop hyperkalemia if the kidney has lost its ability to excrete potassium. Once you hit stage 5 CKD, that's when azotemia develops. Remember that azotemia is the accumulation of waste products in the blood. Usually you have high levels of BUN and serum creatinine. And then remember the associated term uremia. Uremia is the syndrome that develops when you have azotemia. It causes a lot of nausea and vomiting and some confusion when you have that high of waste products in your blood. So now you guys are ready to meet the uremic man. Now, the uremic man was drawn, I believe, in the early 1980s with an early version of paint software. But I'm just attached to him, so I think he's going to stay as long as I can keep him. This poor uremic man has developed every complication of chronic kidney disease that you can imagine. He has these red eyes, which are a result of the accumulation of waste products and even some calcium that gets deposited in the eyes. So he's always feeling very itchy and irritated there. He also has trouble thinking straight because of all the waste products that cross the blood-brain barrier, causing confusion as well. Because he's lost the ability to pee, he gets very volume overloaded if he doesn't restrict how much fluid he takes in. Because any fluid that he drinks is just going to accumulate in his body and not be eliminated by urine. He's got a lot of GI issues. He complains of nausea and vomiting, and everything kind of has a metallic taste because of these accumulated products. He has impaired platelet function. What we've noticed is that the waste products actually bind to the platelets, making them less able to form clots. So he's very prone to bleeding because of this state. We'll spend a lot of time talking about how his kidneys have lost the ability to produce erythropoietin, which is sometimes abbreviated EPO, and he has very severe anemia. Waste products also get to your albumin too. Albumin molecules that are in patients with stage 5 CKD don't bind drugs as well because of all the waste products. And so he actually has higher free fractions of drug floating around than a normal individual would. He's got dry, itchy skin, which is called uremic pruritus. That's when the waste products and calcium deposits get in your skin, making it really itchy. I had a patient once who actually had found the cure-all treatment for this. She was spraying herself with industrial pesticides and said it was great for curing the itchiness associated with uremic pruritus. But I'm pretty sure she was killing the nerves in her skin because the hormone makers don't do that. This guy also has uremic fetor. That is a fancy way of saying that his breath smells like urine. I always think that this would be a great name for has metal bands that you see with people, oh yeah, you're getting like he's hard. But actually, your breath on here. Let's see. The patient, because he can't pee, can get volume overloaded very easily, so he can have trouble breathing because there's fluid in his lungs. We're going to talk a lot about his crazy renal bone disease. Right here, he also develops a certain type of hyperlipidemia because the waste products affect the molecules that carry your lipids around. So the patients with CKD tend to have really high triglycerides and low HDL. And yeah, this poor guy's got reduced reproductive function, restless leg syndrome, and leg cramps as well. So we're going to talk about trying to help this gentleman because hopefully most of our patients are going to end up being really met for a very long time because we're going to try and dialyze him and treat his anemia and his Before I jump into anemia, I just wanted to share a couple of the electrolyte complications that occur with CKD. These shouldn't really be surprising to you, but to be thorough, I wanted to share them with you. So sodium and fluid becomes a big issue in patients with chronic kidney disease. When you hit stage 3 CKD, patients tend to have to get up to go to the bathroom a lot at night. This is because the kidney's tubules have lost the ability to concentrate urine. A normal individual wouldn't have to get up so often because your kidneys kind of kick in and make sure that the urine is concentrated. Patients with end-stage renal disease don't produce much urine, and so they become very volume overloaded if they drink in a lot of water. This is not just a theoretical thing. Like you would see the patient looking like the Michelin Man or like a big droplet of water. You can see all of the fluid that has accumulated in these patients. And of course, when you have that much fluid in your system, it's not great for your heart because that fluid is traveling through your blood vessels, putting pressure on it, and so everything has to work harder. When I was a PGY1 resident, I spent a lot of time working in a dialysis clinic, and I had a patient who would come in for dialysis on Monday, Wednesday, Friday, and every Monday that he came in, he would look like a big bag of water. He was just completely fluid overloaded. And we would have to spend the whole week trying to get him back to a eubulemic state. So one day, I, being the young puppy pharmacist that I was, thought I should go counsel this patient on trying to limit his fluid intake. It's hard to do, but that would solve his problem. He was putting a lot of pressure on his heart. So I went and tried to counsel him. It was clear he had heard this before. Like, this was no big news that I was delivering to him. He was polite, but I didn't get the feeling that I had really reached him. So when we had our multidisciplinary team conference that afternoon, I mentioned that I had tried to talk to him, and the physicians were like, "Oh, you don't know about him?" And I said, "No, what?" They said that he, every Friday and Saturday, would go to a different bar. He would walk in and say, "I bet anyone in here that I will match you drink for drink and not have to go to the bathroom." He was getting, these big yummy guys who were drinking and drinking with him and trying really hard not to go to the bathroom. And little did they realize that he was never going to have to go to the bathroom. He was really cleaning up and making a lot of money by doing this. So it was good for his wallet, but of course not good for his body. That does put pressure on your heart. Another complication that you can see is hyperkalemia, again, because your kidneys are really responsible for trying to eliminate the potassium in the blood. This can be very hard. So patients need to be on a low potassium diet, which can be very hard for them. There's kind of a lot of awesome foods that are high in potassium. Tomatoes, potatoes, hummus is very high in potassium, and so for some folks of Middle Eastern descent who eat hummus on a really regular basis, that can be a huge lifestyle change for them. But this is very real. We had a patient pass away in the hospital whose family had brought in some fresh tomatoes from the garden, and the patient just couldn't help himself and ate a bunch of the tomatoes and passed away that way. I took care of a patient, a young guy in his 30s, who went into cardiac arrest at an Italian restaurant because he was eating a lot of pasta with tomato sauce. Now, this really isn't you're not going to go into cardiac arrest the first time that you eat tomato sauce. It is more of a process that you probably haven't been so compliant in the past and it has built up. But it is a very serious dietary change that patients need to make. And I wanted to point out these cartoons that I'm showing you are from a book called The Lighter Side of Dialysis. It was written by Peter Quaife, who started his life as but during his lifetime was a member of the British rock band The Kinks, and in his later years developed end-stage renal disease, and while he was sitting during these 4-hour dialysis treatments, he would doodle these cartoons. And so it's a great book because it really shows you the patient's feelings about this type of thing, and does inject some humor into the issue as well. The last fluid and electrolyte abnormality that I'm going to mention here is that metabolic acidosis that occurs as your body stops being able to make high carbs. So these patients start to show signs of that around stage 4 CKD. All right, so now we're going to move on to anemia. Patients with stage 4 and 5 CKD very commonly develop anemias, and the main reason that we really focus on is that these patients have decreased erythropoietin production. Your kidney is responsible for producing that hormone, and as the kidney kind of loses its function, it's not able to make that as well. Erythropoietin is the hormone that stimulates red blood cell production in your body. It's also what the exercise Tour de France is doping with, because they're trying to increase their oxygen carrying capacity by increasing the number of red blood cells in your body so that they can illegally, perform even better. But there are also a lot of other reasons to be anemic besides decreased erythropoietin production. Patients with CKD stage 5 have a reduced red blood cell lifespan. So a normal red blood cell is about 120 days, or about 4 months, in a patient. The red blood cells in a patient on dialysis only live half that long. They last about 60 days. And there's nothing wrong with the red blood cell itself, because they've actually taken red blood cells from a patient on dialysis and put it in a normal person. If you take those blood cells and put it in a normal person, it'll live for 120 days. So we think rather than some strange production issue, it's the environment that is causing these red blood cells to die more quickly in patients with CKD. Also, water-soluble vitamins, which are important for the production of hemoglobin, get removed by the dialysis process. That's another reason that you can have issues. Also, the hemodialysis process itself does hemolyze some red blood cells. The way I think about this is when you go to hemodialysis, essentially, we're taking all of your blood, we're running it through a plastic tube, we're shooting it through a filter, and then we're returning it to your body. Your blood wasn't made to touch plastic tubing or to run through a strange plastic filter. And so some of the red blood cells are destroyed just because they're not beefed up to tolerate that process very well. Remember that platelets are adversely affected by uremia, so these patients are more prone to bleeding. And then hyperparathyroidism, which is part of the bone mineral disorder that we'll talk about later, can cause fibrosis of your bone marrow. And your bone marrow is what makes these red blood cells, so you can have issues that way as well. So let's review real quick how erythropoietin is involved in this process of red blood cell production and what goes wrong on a patient's kidneys. So in a normal person, if you sense that you're having decreased oxygen availability, not your brain, but your kidneys senses that you're having reduced amounts of oxygen, it will go ahead and produce hormone erythropoietin. Erythropoietin goes to the bone marrow and causes it to increase red blood cell production. As red blood cells are made, as long as there is enough iron and vitamins, you will make very nice red blood cells, which will correct your anemia and solve that oxygen availability problem. Now, in a patient with advanced kidney disease, there would be decreased oxygen availability. The kidney is supposed to make erythropoietin, but it can't, and so that process is interrupted. We either have to help these patients, we either have to administer an erythropoietin stimulating agent that works very similar to erythropoietin to produce more red blood cells, or we actually have to give the patient blood transfusions to keep their hemoglobin levels high. The reason it's so important that we treat anemia in patients with chronic kidney disease is one, it's a quality of life issue. These patients feel very lethargic, they get out of breath really easily, they report not being able to think as well when they're anemic. And then two, maybe an even bigger issue, is that if you live your life at these really low levels of hemoglobin, your heart has to work really hard to get oxygen throughout the body. And so over time, you're going to be set up for progressive cardiac damage, left ventricular hypertrophy, because anytime you have an organ that's working really hard, it wears out faster. So these profound anemias might be one reason why patients with CKD tend to pass away from cardiovascular causes instead of kidney disease. The anemia of renal failure presents in a certain way. It is normocytic and normochromic. That means the red blood cells are normal in size and normal in color. So it's not really a problem with red blood cell production. There's just not enough red blood cells in the body. Patients will have a low reticulocyte count. Reticulocytes are baby red blood cells, so it's sort of a sign that they're not able to produce new red blood cells. And if we were to measure erythropoietin concentrations, they would be inappropriately low for the degree of anemia that we see. A normal person, if they were very anemic, would have very high erythropoietin concentrations because your body would be trying to stimulate red blood cell production. But just as a side note, don't go looking for erythropoietin concentrations in the lab. It's very rarely measured, so it's not something that you'll commonly see. Oh no! I forgot to plug in my laptop. Challenge yourselves for 5 minutes. We'll be up and running in a second. Stage 3 CKD, you want to start monitoring their hemoglobin levels to make sure they're not developing this anemia, because usually they will, and you'll want to treat it. So when you take that hemoglobin level, if you find that it's low, you're going to think about starting an erythropoiesis stimulating agent, which is sometimes abbreviated ESA. However, I want you guys to be good clinicians that don't just start the ESA. Start thinking about other reasons why there might be an issue. So for example, an ESA is not going to help someone who's actively bleeding out. They're sitting there and they need a blood transfusion and we say, oh, we're going to give you this hormone that bicyclists use. But no, it's not going to work. So be sure you check for bleeds first. And then be sure to check and make sure that you have the fuel that's needed to stimulate erythropoiesis. By fuel, I mean you need to make sure that the patient has plenty of water-soluble vitamins, especially the B vitamins like thiamine and folic acid. These are important cofactors in the enzymes that produce heat. So if you don't have these important cofactors, you're not going to be able to produce red blood cells no matter how much erythropoietin we give you. The other thing you really want to check are for iron stores. Remember that hemoglobin, or each heme molecule of hemoglobin has one iron molecule that carries oxygen around. And so without having enough iron, you're not going to increase the oxygen carrying capacity of the blood. So we need to check and make sure that the patient has enough iron before starting an erythropoiesis stimulating agent as well. When you're thinking about checking for iron, you can order what's called an iron panel. And it comes back with all of these different iron lab values that will help you decide if it's a good iron or not. The serum iron is pretty much useless. It just tells you how much iron happens to be in your blood at the time. It doesn't tell you how much iron is available for your body to use. So basically just ignore serum iron altogether. The two lab tests that you do want to be familiar with for the anemia and in life are the TSAT and the serum ferritin. these first two lab tests that you see up here. A TSAT stands for a transferrin saturation. Transferrin is a substance that carries iron around your body to get it to where it's supposed to go. So a transferrin saturation is telling you how much iron is available on these transport substances. So we want to make sure that the patient's TSAT is above 20%, and if it's below that, you're going to want to give iron. Serum ferritin is the other lab test that you want to look at. Ferritin is the way that iron is stored in your body. So this is a marker of how much is in storage that could be moved around by transferrin if you needed to. For hemodialysis patients, you want that serum ferritin to be above 200 nanograms per ml. So these are key lab values to put into your brain for the exam and to take care of your patients. If iron is low, you will go ahead and start iron products. In early stages of CKD, like CKD 1, 2, and 3 probably, you can go ahead and prescribe regular oral iron supplements. Just remember that there are a bunch of different kinds in the market and that each contain different amounts of elemental iron. So when you get a prescription for iron, make sure that the patient is actually getting, if you have to switch formulations, make sure that they are still getting the same amount of elemental iron that you intended for that to receive. When you hit CKD stage 4 and 5, most patients are going to require IV iron. This is because erythropoietin stimulating agents eat up a lot of iron to make new red blood cells, and so we're never going to get enough iron in these patients with the oral method, so we have to resort to IV. Remember that oral iron is very poorly absorbed. We just want to go ahead and get this iron straight to the source. Plus, you avoid a lot of the GI constipation complications if you can give it IV. So here are some of the iron formulations on the market. Iron dextran is the old school one that's been around forever. And I would say forget about it, but we actually have it on formulary at Gillingham Hospital, so it is still available and something that you want to be aware of. One reason to be aware of it is that it has been associated with anaphylactic reactions. So that's an important thing to know, because when we dispense iron dextran, we actually have to dispense a small test dose first to make sure that the patient tolerates it before you give the rest of the medication. When the medication is being infused, people are actually standing by with a little code card just in case. It's rare, but it's not as rare as with these other iron formulations. Real New Haven Hospital also has iron gluconate and iron sucrose. These agents have to be given in smaller doses that have the lower risk of that anaphylactic reaction. And then the new kid on the block, although it was approved in 2009, can I still call it new? It's the newest of the agents. It's called paramoxicol. This is an interesting agent. It's a superparamagnetic iron oxide, which I had to Google what superparamagnetic meant. And it really just means it's a magnetization that occurs with this type of iron. And this formulation of iron, its niche is that you can give big quantities of it all at once. So if a patient is getting tired of coming in for small IV injections over a long period of time, this might be a medication that you can give. Another weird thing about it is that because it's got this magnetization, if a patient goes for a CT scan, it actually lights up as if you had IV contrast dye. So if you read the package insert, it says, tell your doctor before you have a CT scan if you're on this agent. And it's actually not because anything bad would happen, but because your physician will be freaked out when it looks like you had IV contrast dye on this CT. And they're actually looking into making it an IV contrast dye because it is not toxic to the kidneys. So maybe that'll be the way that we get around all of that IV contrast induced with tubular necrosis. Sorry, that was a little too much on paramoxicol. All right, so for our end-stage renal disease patients that have to come in 3 times a week for hemodialysis anyway, we usually give the iron 3 times a week in small doses because they're there anyway. And we can actually shoot the iron right into the tubing so that we don't have to give them another needle stick. The blood is already out traveling through the hemodialysis filter, so we might as well just shoot it right in there while it's traveling instead of hurting these patients with one more stick. And a total treatment dose of any iron product is usually equal to 1 gram of iron. And the different products kind of break up that 1 gram treatment regimen in different ways. So for example, ferric gluconate comes in 125 milligrams. So you would just give 125 milligrams with each hemodialysis session for a total of 8 sessions. You don't need to memorize that ferric gluconate comes in 125 milligrams. Just remember, a treatment course is 1 gram. For iron sucrose, it comes with 100 milligrams, so you would give that for 10 consecutive dialysis sessions. And then, as I mentioned, this new kid on the block, ferromoxicol, can be given in larger amounts. So you actually only have to come in on 2 separate occasions to get to the 1 gram. So its niche might be patients who aren't on hemodialysis coming in 3 times a week. It might be patients who are at home who don't want to be coming in just to get small doses of iron. You can shoot it up in just 2 doses this way. All right. Any questions about iron? Just got to make sure to replenish those iron stores before you start these erythropoiesis stimulating agents. The 2 ESAs that we have on the market are epoetin, which is sold under the brand name Epogen or Procrit, and darbepoetin, which is Ananac. These substances are very, very, very similar to the erythropoietin that your kidney would produce. In fact, epoetin looks exactly like the erythropoietin hormone that your body would produce. The darbepoetin looks very like the erythropoietin hormone, but do you see these red side chains that have been added? These red, well, they're not red in the left, but these carbohydrate side chains actually make this drug have a longer duration of action in the serum. So, whereas epoetin has to be given 2 to 3 times a week, darbepoetin only has to be given once a week, or in some patients only once every other week. So that's the advantage to darbepoetin, is that you don't have to give it as frequently. So ESAs were developed, the first one was developed in 1989, and I wanted to show you how dramatically they changed practice. Before ESAs were introduced, the only thing that we could do to treat the anemia associated with chronic kidney disease was to give blood transfusions. And when you give blood transfusions over and over again, some patients can develop negative autoimmune responses to receiving foreign blood. In fact, my preceptor, when he was practicing, had to sit with the husband of a 30-some-year-old patient who had developed these negative reactions to blood transfusions, so they couldn't give her blood transfusions anymore, and erythropoietin-stimulating agents hadn't been developed yet. So he had to sit there with the husband as his wife passed away because there was nothing available to treat anemia at that time. But as you can see, in 1989, when ESAs were introduced, on the x-axis here we have the year ranging from 1978 to 1996, and on the y-axis we have the percent of patients requiring blood transfusions. Look how dramatically the number of blood transfusions dropped as soon as ESAs were introduced in 1989. So this was a game changer. We didn't have to lose patients to these severe anemias anymore. Just wanted to point out another couple of reasons why we don't just give CKD patients transfusions all the time, because it is kind of tempting, like, oh, your hemoglobin levels are really low, I know how to fix that really quickly, but we do try to avoid giving blood transfusions, because remember that blood itself is a lot of volume, and these patients are on fluid-restricted diets. So sometimes when we give blood transfusions, we actually have to dialyze the patient at the same time to try and get that fluid off, or we might accidentally fluid overload the patient. Blood also contains a lot of iron. I know we were talking about how these patients actually need a lot of iron, but if you needed a blood transfusion every week for 20 years, you would become very iron overloaded and show signs of iron toxicity. I mentioned the transfusion reactions that patients can get. Of course, blood can be in short supply, and you really want to save it for those patients that really need it. When blood sits around for a really long time, red blood cells tend to release a lot of potassium, and so patients can be hyperkalemic from blood transfusion as well. And then perhaps the most important reason why we want to avoid transfusion is that it can cause transplant issues. If you're giving a patient a whole bunch of foreign blood, it becomes much more likely to reject a kidney than if it hadn't received all of this blood that it produced antibodies to. So for a lot of these patients, we're hoping to get them new kidneys, which would, solve so many of their problems. And so we really have to avoid transfusions if we can help it. When you are monitoring your erythropoietin-stimulating agents, the frequency of hemoglobin testing should be at least monthly, but probably no more than twice a month. The reason I mentioned this is in the hospital, we sort of have our patients as active subjects, and we like to draw their blood every day and see how their hemoglobin is doing. We're probably making them more anemic by drawing that blood every day. So test monthly, but don't overdo it. It takes about 2 weeks after you start an erythropoietin-stimulating agent to see the hemoglobin. This is because you're giving a kickstart to your bone marrow, but it takes time for the red blood cell to develop. At first it makes precursors, and then it matures into a full red blood cell. So you're not going to see changes until at least 2 weeks of test. So that's another reason why I try to get the residents not to drop hemoglobin levels every day, because they're like, oh, it's too low, should I increase the dose? Oh no, let's wait and see what happens. If the hemoglobin level goes too high, instead of stopping the dose altogether, consider decreasing the dose. This is because if you stop the erythropoietin-stimulating agent until the hemoglobin comes down into normal range, when you start it and it takes 2 weeks to get new red blood cells made, you might have already dropped below your target range at that point. So we're trying not to cycle between levels of too high and then too low and then too high by decreasing the dose instead of holding it all together. Right. One more debate that's out there about erythropoietin-stimulating agents is whether or not to give them IV or subcutaneously. If you give an ESA subcutaneously, it takes longer to be absorbed, and so it has a longer duration of action, which is a little bit more physiologic, kind of like what your natural erythropoietin will do. If you give it IV, it has a shorter duration of action, and so we often have to use higher doses of erythropoietin-stimulating agent if we give it IV. However, IV means you can just shoot it right into the tubing of the dialysis machine, and patients don't have to be poked. So some hemodialysis patients prefer the IV route of administration. So I want to take a quick poll. How many of you guys, if you were on dialysis, would want subcutaneous erythropoietin? Raise your hand. It's more physiologic. I see a couple. And there's a real pro to it in that it seems to, you can use lower doses and it seems to have a more sustained response. All right, so now you all better raise your hands for IV. Is that what you guys are thinking? All right, I'm seeing a lot of not. So a lot of people would rather not be poked 3 times a week and get that IV infusion. That is what a lot of dialysis patients end up preferring as well. The reason I'm mentioning this is that the debate also has to do with cost issues. So remember that dialysis clinics tend to be for-profit organizations, and if you give a subcutaneous injection, you can use lower doses of an erythropoietin-stimulating agent and save money. So a lot of dialysis clinics are starting to trend more towards giving these agents subcutaneously. Just to fill you guys in on all of the kind of monetary issues related to dialysis, in 1971, a patient was dialyzed on the Senate floor. They set up the machine right there with all of the senators, and they dialyzed the patient. The senators were so impressed with this life-saving technology that they passed a bill that said that Medicare will pay for all dialysis treatments, including medications, for all patients so that nobody can be denied this life-saving therapy of hemodialysis. That's great. I love that no one can be denied this. However, just remember that when they passed this bill, there were about 4,000 patients on hemodialysis in the 1970s. Now there are over 500,000 patients on hemodialysis, and we spend over $17 billion a year on these techniques and medications. So this is a large portion of the Medicare budget going to help dialysis patients. I'm not saying it's wrong, but I'm trying to show you how there's these monetary issues where they say, oh, maybe subcutaneous would be better because I can use less ESA that way of saving money. Here's just a illustration to show you the differences between IV and sub-Q. If you had, let's say your body releases erythropoietin at a steady rate, like this line here. If you don't have any erythropoietin of your own to produce, we can give you an ESA. With a subcutaneous, you have these lower peaks and prolonged times that it's in your body, whereas with the IV, you get kind of a bolus where you get a really high peak, and then it returns to low concentrations quickly. So really, the sub-Q is really kind of more like what your body would do, although we still do see some success with IV administration as well. All right. So here are the hemoglobin targets that we shoot for in patients with chronic kidney disease, and they have changed a lot over the years, and they're going to change while we're in practice for sure, because every couple of years they announce a new hemoglobin target. So for example, in 2000, the National Kidney Foundation KDOQI guidelines said that hemoglobin levels should be kept between 11 to 12 in dialysis patients. Then they updated their guidelines, even though not a lot of research was published, in 2006 to say you should shoot for a range of 11 to 13. Some people say that the people that were making the guidelines were also employed by the erythropoietin manufacturers, because all of a sudden they said, hey, higher hemoglobin levels are better, even though there was no research to necessarily indicate that. Medicare has pretty stably said to shoot for a range of 10 to 12, and they will not pay for erythropoietin-stimulating agents for patients that have hemoglobin levels that are much higher than that. And then the FDA has been weighing in on this as well. They used to say to shoot for a range of 11 to 12, but in 2011 made this huge announcement that for dialysis patients you should shoot for 10 to 11, and for patients not on CKD, only give enough of an erythropoietin to avoid blood transfusions. So what we're doing now in practice, and what you should know for the exam, would be this FDA recommendation of 10 to 11 grams per deciliter for dialysis patients. But just remember that in a few years they might make another announcement and change this range. Now I wanted to point out, here are some normal hemoglobin levels. For a male, it's 13 to 18 grams per deciliter, and a female, 12 to 16 grams per deciliter. Do you notice that our target goals are much lower than a normal hemoglobin? This isn't actually to save money, although that would have been my guess. We've actually found that maintaining lower hemoglobin levels is better, because higher hemoglobin levels increase mortality. This was shocking. When erythropoietin-stimulating agents came out in 1989, we said, well, it's common sense to shoot for higher hemoglobin. Let's get people into the normal range. But what studies have found, and I know this is a really busy slide, but just take away the title here, that clinical trials have found that there is a greater cardiovascular risk when hemoglobin targets are pushed up to normal levels of 13 grams per deciliter. This was shocking to the community. Whenever you go to a lecture on why we use evidence-based medicine, this issue comes up, because we always thought that it was common sense to push hemoglobin levels into normal range. But what trials have found is when you increase hemoglobin levels above 13, patients had, in this trial, an increased risk of death or non-fatal MI. In this trial, they had increased risk of death or hospitalization for CHF. And in the third trial, they had increased risk of stroke. So that's why we don't try to normalize hemoglobin levels anymore. We're not sure exactly why cardiovascular risk is increased. What we think is that if you're stimulating a whole bunch of red blood cells, it kind of thickens your blood a little bit, and maybe that thickening of the blood is what's causing MIs, strokes, and these other hospitalizations. So I feel like I've been talking for a while, so let's take our 10-minute break now. And when we come back, we'll finish anemia real quick. I'll introduce some of the issues associated with bone mineral disease, and then I'll turn it over to Dr. William. Would be, if you have an anemic patient, make sure they have adequate iron stores before starting your ESA. Know how to titrate it. Remember, it's not something that you would change the dose of every day. Know about some of those IV versus subacute issues. And then finally, I have a slide on adverse events. To be honest, the only adverse event that I've seen is this first one here, hypertension, which occurs at a similar rate between darbepoetin and epoetin. In fact, these two agents have very similar adverse effect profiles. So when you are studying for the exam, if you want to focus on hypertension, that's just fine. The other ones, I really don't see that often. If you pull up the prescribing information for epoetin and darbepoetin, it'll say hypertension is a side effect, but it is not a contraindication to starting an ESA. And that's important to know because even if a patient is very hypertensive, if they're super anemic and they're going to pass away from their anemia, it's more important that we give the ESA and treat the blood pressure with blood pressure lowering agents. So this is one of the few times that I think polypharmacy is okay. It's okay to treat the adverse event associated with this drug with another drug because it's that important to keep these patients' hemoglobin high. Alright, so that was anemia in a nutshell. Now we're going to move on to a really crazy complication of end-stage renal disease. It still kind of blows my mind every time I teach it, and that is chronic kidney disease, mineral and bone disorder. I know that's kind of an unwieldy name. It's abbreviated CKD-MBD. It's still kind of a mouthful to say. CKD-MBD is an umbrella term for any of the abnormalities that you might see occurring with your calcium, phosphorus, and bones that are when you have end-stage renal disease. So if a patient has any abnormalities of calcium, phosphorus, parathyroid hormone, or vitamin D metabolism, remember that the kidney activates your vitamin D. You'll be said to have CKD-MBD. If you have any abnormalities in your bone turnover, your bone mineralization, or your bone growth, that counts as CKD-MBD. Or if you have any soft tissue calcifications, you have CKD-MBD as well. So I'm going to start out, this is sort of a complicated, crazy thing that happens. So I'm going to start out at the very beginning and then introduce you to this vicious cycle that can occur that will lead to the demineralization of your bones. So let's start by asking ourselves what parathyroid hormone does. I asked my husband a few years ago what the parathyroid hormone did, just as I was working on this slide set, and said, does it have something to do with the thyroid? It does not. It is near the thyroid, but it is not your thyroid hormones. They exist kind of in the throat behind your thyroid gland. The parathyroid glands, you have 4 of them, work to regulate calcium in your body. And by regulating calcium, they also regulate phosphorus because you never want to have high levels of calcium and phosphorus together because that's when you see crystallization of calcium phosphate issues. Alright, so let's look at the normal function of the parathyroid hormone and then we'll review how everything goes awry when your kidneys poop out. So let's say that you have low levels of calcium in your blood. The parathyroid gland actually has a calcium sensing receptor on it, and if it senses that there are low calcium levels, it will secrete parathyroid hormone into your body. The parathyroid hormone will then try to increase your calcium in 3 different ways. First, it'll go over to the kidney and say, hey kidney, our calcium is low, go ahead and reabsorb all of the calcium that you can. Don't pee out any calcium. We need it. At the same time, it also encourages if you need to eliminate some phosphorus, just so that you don't have high levels of both calcium and phosphorus. The parathyroid hormone, while it's over at the kidney, also says, hey kidney, why don't you make some more active vitamin D so that we can absorb more calcium into our GI tract. That way we can get as much calcium from our diet as possible as well. It's not until the parathyroid hormone has tried both of these mechanisms and failed that it'll go over to your bones. And it can actually dissolve your bones, which are made of calcium phosphate, and that will increase your calcium levels as well. We really don't want it stealing calcium from your bones too often because we want your bones to be strong and healthy. So that's kind of its last resort. The parathyroid hormone is very tightly regulated by feedback mechanisms. Things that will increase the expression of parathyroid hormone include those low calcium levels that I mentioned, because it has a calcium sensing receptor. And high phosphorus tends to increase the expression of the hormone as well, because the hormone likes to promote phosphorus excretion. Things that decrease the expression of the parathyroid hormone would be high calcium levels, because then you don't need it trying to raise your calcium anymore. And actually, high levels of activated vitamin D will decrease parathyroid expression as well, because it'll say, oh, I caused enough activated vitamin D to be made by the kidney, so I'm going to shut that down. So those are the things that kind of can regulate what your parathyroid does. All right, now let's look at what happens when your kidneys poop out on you. We've got a poor person with renal dysfunction, so we know that they have decreased activation of vitamin D because they've lost that function in the kidney, and we know that they're not able to excrete their phosphate as much either. Both of these things cause the parathyroid hormone to be released to get out there and raise calcium levels. But when the parathyroid hormone goes to your kidneys and says, hey kidneys, hang on to all of the calcium possible, please, the kidneys don't respond because they're like not even a part of the picture anymore. And when they go over to and they say, while I'm there, hey kidneys, can you increase the activation of vitamin D so that we can absorb more calcium in our GI tract? Again, the kidneys are like, oh, I'm not doing anything now, I'm sick. So the parathyroid hormone has to go over to your bones and start demineralizing them to release more calcium into the blood. Unfortunately, when it starts pulling calcium from your bones, because your bones consist of calcium phosphate, you also release a large amount of phosphate into your blood as well. When you have high levels of both calcium and phosphate, you run the risk of vascular calcification. That basically just means that your bones mineralize in other parts of your body instead of your bones. You're going to get calcium phosphate crystals in your lungs or in your hands instead of where they belong, in your bones. Once these crystals precipitate, your calcium levels are going to fall again because all the calcium is in this crystal form. And so the parathyroid hormone gets released again to increase the calcium in your blood. So you can see how it ends up being a vicious cycle of the parathyroid hormone pulling calcium and phosphorus out of your bones. That crystallizes, so your calcium level drops again, and more parathyroid hormone is excreted. Any time that you have an organ working harder than it's supposed to, you run into trouble. So I know this is a complicated slide, but I threw it in there to remind myself to tell you that the parathyroid hormone becomes very hypertrophied because it's doing all this work. It's releasing parathyroid hormone constantly, trying to get your calcium levels up in your blood. So it starts out looking all normal, but as you progress to renal failure, your parathyroid hormone gets bigger and bigger, and it's pretty unrecognizable if you don't treat this condition. And the reason I wanted to tell you that it kind of changes over time is that all of a sudden, this parathyroid hormone gland does not respond very well to those feedback mechanisms of high calcium or high vitamin D. Things that should shut it off don't shut it off anymore. So I feel like I did the best glad I put in the slide that gives me a chance to say everything again. Remember that when you have kidney disease, you have decreased calcium absorption because you don't have as much active vitamin D3, and so you have low calcium levels. This causes your PTH to be released to try to raise your calcium back up to normal levels. Unfortunately, most of the ways that it would raise your calcium are not available to it anymore because your kidneys have pooped out. So the only thing it can do is demineralize your bones. When it demineralizes your bones, your calcium and phosphorus levels rise enough that you sometimes get calcium phosphate crystals forming in other parts of the body. And the parathyroid hormone gets stuck, continually secreting parathyroid in this vicious cycle that's really leading you just to have kind of the worst bones in the world and kind of calcium phosphate crystals throughout the body. You don't have these slides in your deck because I'm going to get you to have to print out x-rays, but here is, I'm no radiologist, but here, these white calcified markings are mineralization of your lungs. So this is where calcium and phosphorus was high in your bloodstream, and so your bones basically kind of re-precipitated into your lungs. Here's a picture of somebody's shoulder that's calcified. All of that white area around the bone is extra calcium phosphorus deposition. This patient, my fellowship preceptor actually worked with, this was a girl in her 20s whose mother did not believe in modern medicine, and so she said, don't take any of the treatments that Dr. Lemieux is going to talk about. I will cure you herbally and with, I forget, she had some kind of chant that she was going to do as well. The problem with that is that these treatments that she was trying to do weren't working, and she ended up having these huge deposits in her hands, which you can actually see would look kind of like this if you didn't have a CT scan. Her calcium and phosphorus issues were so progressed that if you stood close to her, you would hear a clicking noise. That was the sound of her calcified heart valves clacking together. So this is a very extreme case. This doesn't happen to everyone. She actually ended up needing a parathyroidectomy, where we take out the parathyroid so that we can avoid some of these issues. In Japan, they used to just inject alcohol right into your parathyroid gland. That'll kill it, that for sure, that way. Here, we tend to take out all four of them, but we'll put one in your arm here that can still secrete some parathyroid hormone so that your calcium levels don't drop in a big way. Why do you think you put it in your arm instead of just leaving it in your neck? Any thoughts? It's just, if we have to go and get rid of it, it's much easier to do a surgery on your arm than to do a very invasive surgery on your neck. So it still works from your arm, so we might as well keep it there where you can get to it. As evidenced by that story about hearing the clicking of the heart valves clicking together, you really want to treat CKD MVD so that you can avoid cardiovascular risk. You do not want to calcify your blood vessels because that causes heart failure and ischemic heart disease. Finally, I wanted to show you your treatment goals for a patient with CKD MVD. And I only want you, when you're studying, to focus on the ones that occur in your end-stage renal disease patients. So you want to think about your phosphorus goals, your calcium goals. Interestingly enough, you want to think of your calcium phosphorus product. Because you don't want to have high levels of calcium and phosphorus in your blood, we want to keep your calcium phosphorus product below 55, because when it's above 55, that's when we see crystals starting to appear. So calcium phosphorus product would be an important thing to memorize. Finally, our goal for your PTH hormone, which is measured in something called an IPTH or intact PTH, is to keep it between 150 and 300. This is much higher than normal. Most patients like you guys would have a PTH probably of like 35 or even less. So, but we try and control it as much as we can. Okay, with that, I'm going to turn it over to our guest speaker, Dr. Lemieux. He will review the therapeutics for treating CKD.
All right, good morning, everyone. So, as Dr. Eiler said, my name is Dr. Renal. I recognize most of you from GI module last semester, but in case you forgot, I'm now one of the PGY2 critical care residents at Yale New Haven Hospital. And instead of talking about GI-related topics, today I'll be speaking to you more so about the kidneys. So, my topic today will be treatment options that exist for chronic kidney disease, mineral and bone disorder, which I'll abbreviate to CKD-MBD for the rest of the lecture. The biggest thing I want you to keep in mind throughout the next half an hour or so when we go through this is really our ultimate goal in treating CKD-MBD with these various agents is going to be to prevent various complications which arise from this disease. So things that Dr. Eiler introduced, such as bone mineralization deficiencies, vascular calcifications, and cardiovascular events. If we can do this, ultimately we can decrease morbidity and mortality from this disease. My objectives for you today are to be able to recognize various complications associated with the progression of chronic kidney disease, or CKD, describe the mechanisms of currently approved agents used to correct underlying mineral and bone disorders in CKD, apply knowledge of these agents, which we'll learn about, to devise a treatment regimen tailored to a specific patient, and lastly, identify a novel treatment approach which may be utilized in future practice for this patient population. Now, I'd like to start by revisiting this slide presented by Dr. Eiler a little while ago and essentially interpret what's going on here. So, what do we have? We have this cascade of hyperparathyroidism essentially driving vascular calcification, and from that we get subsequent hypocalcemia, right? And so, from this we have our underlying pathophysiology of chronic kidney disease, mineral and bone disorder. So it may be helpful when we're going through the remaining slides and talking about various treatment options to refer back to this cascade. And one can definitely see how the treatment options we're going to be giving are going to work to correct this underlying pathophysiology. Our ultimate goal is going to be to normalize PTH. If we can do that, then we can prevent these various complications we talked about in CKD-MBD from occurring. What are our treatment options? Well, in current practice, there are three main approaches which we currently take. First and foremost, we try and decrease serum phosphorus in these patients. Our first line approach to doing this is through dietary phosphorus restriction. Many patients struggle significantly with this, therefore we often need additional help through the use of pharmacologic phosphate binders, which we'll discuss. Our second option we typically do is we supplement the physiologically active form of vitamin D in these patients, which is our 1-alpha 25-dihydroxy vitamin D3. And the importance of this we'll discuss later, but essentially it's important that it be active. And then our last line approach essentially is reduce parathyroid hormone activity through the use of calcimimetic, which by definition is a compound which mimics the effects of extracellular calcium at the calcium-sensing receptors of the parathyroid glands. Again, the importance of this we'll discuss in future slides. The important takeaway here is that, again, our ultimate goal is to normalize PTH, but what's important to remember is that changes are going to be interrelated. So, for example, if we were to give vitamin D to somebody to help suppress PTH, unfortunately, that's not going to be the only thing we're going to be doing. We're going to be affecting calcium and phosphorus as well, which we'll see. So just keep that in mind. And really what this sets the stage for is in the management of these patients, it's this continual game essentially of going back and forth with their electrolyte abnormalities and looking at them on a daily basis and saying, okay, what is it that we need to normalize today? And then tomorrow we reassess and do the same thing since all of these interrelationships exist. We'll start with treatment option number one, which is limiting our phosphorus. So again, our first line approach is limiting our dietary phosphorus intake to 800 to 1,000 milligrams per day. The key message here is that this is very difficult to do. So just to give you a frame of reference, one standard 8-ounce glass of milk has 230 milligrams of phosphorus in it. So if you do the math, all it takes is 4 glasses of milk and you're already at your phosphorus limit for the day, which obviously is not very much. So other things that are high in phosphorus would be other dairy products, seafood, turkey, Coca-Cola. really delicious things, really. So a lot of our patients have trouble just maintaining full phosphorus levels through dietary restriction in itself. And that's why we have our phosphate binders. Mechanistically, what these medications do is they contain cations, which bind dietary phosphate, which is anionic, and the effect that this has is it forms insoluble complexes, which are then able to be excreted in the feces rather than systemically absorbed. So as we can see from the slide, there are a lot of cations which have been used historically in pharmacologic phosphate binders. However, the most simple classification that I can offer for these agents is simply calcium-containing versus non-calcium-containing. Of our calcium-containing phosphate binders, we have calcium acetate and calcium carbonate. Whereas for our non-calcium-containing phosphate binders, we have sevelamer and lanthanum, which are most typically seen in current practice. We also have some newer agents on the block, ferric citrate and sucroferric oxyhydroxide, as well as this other category, which is really a miscellaneous group of non-calcium-containing phosphate binders that have fallen out of favor in current practice for various reasons. And again, the reasons for that we'll discuss. We'll start with our calcium-containing phosphate binders. So the very first one we'll talk about is calcium acetate, which comes in 667 milligram tablets. We start with a dose of 2 tablets with each meal, and we'll essentially titrate that dose every 2 to 3 weeks to achieve full phosphorus levels. And the main side effects we'll observe are GI in nature, so our typical nausea, vomiting, and diarrhea, as well as hypercalcemia, again, given that this is a calcium-containing phosphate binder. And then our other option is calcium carbonate. So this comes as 1,250 milligram tablets with the same starting dose, titration schedule, and side effects that we would see with calcium acetate. Now, in terms of comparing these two agents, there are some subtle differences between the two. So one of the advantages of calcium carbonate is that it's available over the counter versus calcium acetate, which requires a prescription. And calcium carbonate is also cheaper than calcium acetate as well. However, between these two, calcium acetate is the better phosphate binder, so it has a higher affinity for dietary phosphorus. So really, if we're choosing between the two, we really prefer calcium acetate, unless the patient has some extenuating circumstances. For example, if they can't afford calcium acetate, then that patient would be suitable for calcium carbonate for phosphate binding instead. Now, what about calcium citrate? So this is something we give as calcium supplementation in other patient populations. Could we use this as a phosphate binder? We should. And the reason is because it's contraindicated due to the fact that citrate increases aluminum absorption, and aluminum is removed by the kidneys. So we set the stage for aluminum accumulation, which is problematic because aluminum accumulation is associated with neurotoxicity. So typical symptoms that one may see from aluminum toxicity would be speech disturbances, encephalopathy, seizures, your typical neurotoxic symptoms. Again, things that are better avoided in these patients, and for that reason, we contraindicate the use of calcium citrate in our CKD and B2 patients. At this time, I'd like to introduce our first patient. So patient LD, a 68-year-old male with stage 5 CKD, requiring hemodialysis secondary to uncontrolled hypertension. His serum calcium is 8.8, and phosphorus is 6.5, despite dietary phosphorus restriction. The medical team orders calcium acetate 2 tablets orally 3 times a day with meals, and asks you to verify their order. How do you proceed? Do you A, verify the order, because calcium levels are normal and our focus should be to reduce phosphorus? B, recommend the team start calcium carbonate rather than calcium acetate? Or C, obtain the patient's albumin level and calculate corrected calcium before moving forward? And what I'd like you to do is take out your phones, and we're going to use some polling software. So, essentially, if you're not familiar with the software, how it works is based on what you feel is the appropriate answer to this question. You will text the corresponding number to the telephone number 22333, and we should see in real time what the audience thinks. So, let's see. Does anyone need to see the question again? Okay. Okay. So I think we have an overwhelming majority for this question, which is good because you guys picked the correct answer. So C, always calculate the corrected calcium before assessing a patient's calcium status. The reason for this is because calcium combines to albumin, and the calcium that's found to albumin essentially has no physiologic effects. It's only the unbound calcium that we need to concern ourselves with. Therefore, calculate your corrected calcium through the equation introduced earlier in the lecture, which we do. And so, being the good pharmacy student that you are, you take a look at the albumin level and find that it's 1.8. So, what is the corrected calcium level? Is it A, 10.56, B, 7.04, or C, 13.44? Once again, great job. 10.56 is the correct answer. So really the key here is remembering the order of operations. So subtract albumin from 4 first, multiply that times 0.8, and then add that to your serum calcium level. And this patient should come out to 10.56 milligrams per deciliter. Great job. Lastly, you're now more confident in your ability to make the appropriate decision. What do you decide? A, verify the calcium acetate order. Phosphorus levels should be reduced even in the presence of hypercalcemia. B, recommend the team start calcium carbonate rather than calcium acetate because it binds phosphorus more potently. C, suggest the team utilize non-calcium containing drug therapy to lower phosphorus levels. Or D, recommend calcium citrate instead. Excellent job, guys. C is the correct answer. So we wouldn't recommend calcium citrate, right, because that's contraindicated in our CKD-MVD patients since it increases aluminum absorption. B is not correct because the reverse is true. Calcium acetate is the more potent phosphate binder. And then in terms of differentiating between A and C, really what's important to remember is that the calcium from our calcium-containing phosphate binders does contribute significantly to vascular calcification. So really in that type of patient, if a non-calcium containing phosphate binder would be preferred, which is what we're going to speak about next. Question? Not in my experience. I mean, really, in terms of when we see those kinds of patients, we generally just switch them from the calcium-containing to the non-calcium containing. To be honest, most of the time, they are already on that non-calcium containing phosphate binder when they come into the ICU, which is where I see them, because they've had that problem upstream. But not to my knowledge. I'm not sure if Dr. Iron has...
Calcium comes because you have to use more of them to get the phosphate lowering that you want, will lead to more calcium absorption, theoretically. Although, if you've got someone who can't afford the Foslo, we're going to do what we have to and prescribe the Tums.
So in terms of our non-calcium containing phosphate binders, the one we see most typically is sevelamer, which comes as 400 and 800 milligram tablets. And our starting dose depends on our serum phosphorus levels, such that the higher our phosphorus level is, the more sevelamer this patient will be taking. Structurally, this medication is a non-systemically absorbed cationic polymer. So again, the cation will bind to that anionic dietary phosphorus, will form that insoluble complex, which can then be excreted rather than systemically absorbed. So, if one was to consult the package insert for sevelamer, one would see that it's touted as a medication that is claimed to be free of drug interactions. However, structurally and mechanistically, this medication is very similar to a bile acid sequestrant. Therefore, we can expect that in terms of concomitantly administered medications, administering sevelamer would decrease their bioavailability. Therefore, it's not necessarily free of drug interactions. And really, when we administer sevelamer, we should make the recommendation to, if there are any other concomitant meds, to administer them at least 1 hour before or 3 hours after sevelamer administration. The benefit to it being similar to a bile acid sequestrant is that it does have some LDL lowering effects. They're very modest, but they do exist nonetheless. Another potential advantage for sevelamer, so it doesn't contain calcium, which, again, in a hypercalcemic patient is desirable. It also doesn't contain magnesium or aluminum, which, again, can accumulate in renal dysfunction, so that can be favorable as well. One thing that will come up is sevelamer tablets are very large, and they can't be crushed. So this can be problematic for someone who has trouble swallowing large tablets. However, there is an oral suspension available for this patient population, or if you have somebody in the intensive care unit who's intubated and has a G-tube in place, there is an oral suspension that we can administer down that tube, rather than having to crush the medication, which we can't do in this instance. Our other non-calcium containing phosphate binder we see a lot is lanthanum, which we recognize from the periodic table of elements. Comes as a 500, 750, and 1,000 milligram chewable tablets. So chewable can be advantageous again in somebody who's having trouble swallowing large tablets. The starting dose is 1,500 milligrams per day, divided and taken with meals, which will titrate every 2 to 3 weeks to achieve goal phosphorus. And then our side effects, typically, again, nausea, vomiting, diarrhea, as well as abdominal pain. So between lanthanums and sevelamer, we typically use sevelamer more, and the reason for that is because, similar to aluminum, lanthanum is a heavy metal, so there are concerns that lanthanum may end up turning out just like aluminum, where we can set the stage for neurotoxicity. And in fact, lanthanum has been shown to accumulate in the bones of CKD patients. Therefore, due in part to concerns that lanthanum may end up being in the same boat as aluminum, we generally just tend towards the cautious side in this instance and use sevelamer instead. The problem is that long-term data just isn't available at this point. So lanthanum was FDA approved in 2004. Therefore, it really hasn't been in practice long enough to see potential long-term complications like have been observed with aluminum in this patient population. So just important to know that you'll see more sevelamer in practice for that reason. Ferric citrate is one of the newer phosphate binders, which are non-calcium containing. Comes as 1 gram tablets, each of which has 210 milligrams of ferric iron. We start with 2 tablets 3 times a day, and then increase our dose every week to achieve our goal phosphorus levels once again. Our maximum dose is 12 tablets daily, and our side effects are what we typically saw before, in that we have nausea, vomiting, diarrhea. We also have darkening of stools, as well as cough that's been observed with ferric citrate. And then our other new kid on the block is sucroferric oxyhydroxide, or Velphora, which comes as 500 milligram chewable tablets. Again, chewable can potentially be advantageous. We start with 500 milligrams 3 times a day and increase every week to goal phosphorus, up to a maximum of 3 grams per day. And then the side effects, similar to what we saw with ferric citrate, GI, and darkening of stools. We also have observance of altered sensation of taste in these patients as well. So that's one of the ones that's sort of more unique to Velphora among this class of medications. Then we transition into that other category that I explained earlier, which are the phosphate binders, which have fallen out of favor in current practice. So we have the magnesium phosphate binders. These have fallen out of favor because magnesium is eliminated by the kidneys. So again, we can have magnesium accumulation in these patients. They also contain aluminum, which we know is neurotoxic. So for that reason, they generally aren't used much for phosphate binding. And then, of course, aluminum phosphate binders. Again, given that aluminum is neurotoxic, we usually stay away from them in terms of phosphate binding in the CKD and MBD patient population. In terms of an efficacy standpoint, they really are strong phosphate binders, so it's unfortunate that we have these adverse effects associated with it. If aluminum phosphate binders are to be used, really their use should be limited to 2 to 3 doses. Again, their efficacy is very good, but because of the neurotoxic side effects, generally we should just steer clear of them. And to really drive home this point of aluminum toxicity so that it'll stick with you guys, I wanted to include this case report published by Zada and colleagues in 2004, which was the case of a 59-year-old male with stage 4 CKD secondary to diabetic nephropathy, who reported a history of gastric pain, that he had been using Maalox for 3 years to self-treat. In the clinic, the patient was noted to have speech disturbances, and so they were a little uneasy in the clinic. They admitted him to the hospital for further assessment. So they admitted him, and as an inpatient, began to exhibit spontaneous tremor and encephalopathy, which they eventually attributed to aluminum toxicity. These neurologic symptoms continued to progress during his inpatient stay, ultimately to recurrent seizures, and this patient ultimately died of cardiogenic shock. So, again, hopefully this drives home the point where aluminum toxicity with the use of phosphate binders containing aluminum in the setting of CKD and MBD should be highly discouraged. They have great efficacy, but because of their horrible adverse effect profile in this patient population, we should just steer clear. Additional points that I'll mention about phosphate binders before moving on to our other treatment strategies. Remember that common sense says phosphate binders should always be taken with meals. Therefore, if you skip a meal, skip your dose, right? So mechanistically, these medications work because they bind dietary phosphorus. So if we're not eating, we don't need to take a phosphate binder. It's going to give us no benefit. So this is something that I've actually seen patients not understand in the past. It's important, if your patient's new to a phosphate binder, that you explain this to them. It's a great way to reduce that pill burden and save them money as well. There's also, on that subject, many potential barriers to adherence with the use of phosphate binders. And the reasons for this are manifold. So one of the reasons is because we have that very high pill burden with phosphate binders. What we saw with ferric citrate, for example, we had a maximum dose of 12 tablets daily, right? I mean, that's ridiculous. So as you can imagine, a lot of patients are not perfectly adherent to these medications for that reason. Another reason why adherence is very poor with phosphate binders is because, similar to blood pressure, patients aren't going to experience any subjective benefit when they take their phosphate binder. By lowering their phosphorus, they're not immediately going to feel all cured. And really what they're more likely to experience are the GI side effects we talked about, so nausea, vomiting, and diarrhea. So their rationale may be, well, this medication makes me feel poorly, why should I take it? And so it's important that we use tactics that we've learned, like motivational interviewing, take the time to speak with these patients about these potential barriers and how we can overcome them to ensure proper adherence and to optimize their therapy. And with respect to the GI side effects in particular, these tend to diminish over time. So this is another important point that we can tell our patients in order to encourage adherence. Any questions about phosphate binders, calcium or non-calcium containing, before we proceed? Okay. So we'll move on to option number 2, which is supplementing active vitamin D. Now, vitamin D3 is synthesized endogenously in your body upon exposure to ultraviolet light. And from there, it undergoes bioactivation through a series of hydroxylation steps, one of which is performed in the kidney. So as one might expect, this process occurs to a lesser extent in patients with CKD and MBD. Therefore, they are predisposed to having less active vitamin D, and as a result of that, being hypocalcemic. Therefore, our treatment strategy in these patients will be to administer already activated vitamin D analogs, that 1-alpha 25-dihydroxyvitamin D3, to increase calcium absorption and decrease PTH secretion. And of those active vitamin D analogs, we have 3 of them that are currently approved for use in the United States. There's calcitriol, paracalcitol, and doxorcalciferol, all of which are available IV and PL. The specific dosing and titration of these depends on a number of things. It depends on the stage of CKD, as well as our intact parathyroid hormone levels. What's important to note is, given that they're all PO and IV, the regimens do differ, so it's not as simple as a 1-to-1 conversion. But ultimately what we're doing is we're titrating to resolution of hyperparathyroidism. So again, our ultimate goal being normalization of PTH. That is what we're ultimately trying to do in these patients when we administer active vitamin D. It's worth noting that there are differences among the three. So calcitriol is the oldest of the three. And paracalcitol, for example, is less hypercalcemic and less hyperphosphatemic than calcitriol. And when paracalcitol and doxoricalciferol came out as the newer active vitamin D analogs, there were claims that they may suppress PTH more smoothly and have mortality benefits compared to the older calcitriol. But thus far, this is yet to be proven in clinical studies. Now, since these are all available IV and PO, this begs the question, which route of administration do we choose? On the one hand, IV pulse doses of active vitamin D analogs more effectively downregulate PTH secretion than PO administration, which again is our ultimate goal, so that's a favorable thing to do. On the flip side, PO increases the GI absorption of calcium more so than IV, so these patients may be hypercalcemic, which can be a beneficial thing to do. However, with calcium, it's also going to increase phosphorus absorption too, so that can be detrimental in that these patients with CKD can be hyperphosphatemic more often than not. So the take-home message here is to individualize therapy. So look at your patient specifically, and based on their presenting labs, choose what dosing administration is best for them, based on what you know about IV and PO and what you know about your patient as an individual. It's also worth noting that, similar to what Dr. Eiler explained earlier about the ESAs, typically this decision is made based on the stage of CKD. So if you have a patient who's not yet on hemodialysis, typically we will choose PO because the patient doesn't have to get poked. Obviously, it's more patient-friendly than administering an IV. Versus if you have a patient who's on hemodialysis 3 times weekly, then oftentimes we opt for the pulse doses of the active vitamin D analogs 3 times a week with hemodialysis. The reason is just because it's easy. So the patient already has a line in them. What do? We just inject the active vitamin D into the blood in the dialysis machine. It circulates back into the patient. Very easy to do. So again, in a patient who's on dialysis, typically what will dictate our decision of doing IV is just that it's convenient versus PO with someone who's not on dialysis. Regardless of which method of administration you choose, you should monitor calcium, phosphorus, and intact parathyroid hormone levels throughout your course of therapy, ultimately to ensure that calcium phosphorus product we discussed earlier is less than 55. Key points with respect to administration of active vitamin D. Remember, active vitamin D only. So we see agents like ergocalciferol and cholecalciferol commonly in practice, which are very useful for someone with a chronic vitamin D deficiency. But these are precursors. They're not active vitamin D. They still need to undergo hydroxylation and activation in the body. Therefore, ergocalciferol and cholecalciferol are not useful in this patient population for what we're trying to achieve. We need to use either calcitriol, paracalcitol, or doxoricalciferol. And lastly, I just included a sample regimen for doxoricalciferol, again, to drive home the point that the PO and IV pulse dosing regimens do differ. For the purposes of the exam, don't memorize dosing here. Just be cognizant of the fact that PO and IV regimens differ. Questions about active vitamin D analogs? Okay. Then I'll introduce our next patient, patient CC, a 72-year-old male, admitted to your hospital with a bloodstream infection. Labs reveal intact parathyroid hormone level of 700, albumin of 4, corrected calcium of 9, and phosphorus of 4. The medical resident would like to order vitamin D, but asks you to prescribe the regimen because she knows renal module was your favorite class in pharmacy school. What are your thoughts? Would you A, order calcitriol 0.5 mics PO daily? B, suggest the resident order IV pulse doxoricalciferol 3 times weekly? C, order cholecalciferol 1,000 international units PO daily? Or D, vitamin D is completely contraindicated in this patient? So we have some mixed results here, but let's just go through. So basically, when we go through our choices, C, again, cholecalciferol is a precursor, doesn't have much utility in this patient, CKD, MDD. D is incorrect. There's no reason why vitamin D would be contraindicated in this particular patient. So this brings us down to A and B. So essentially, PO versus IV active vitamin D. Remember that IV vitamin D's benefits are that it more effectively suppresses PTH secretion than PO. And PO, on the flip side, increases calcium and phosphorus absorption through the GI tract better than IV. Given that our ultimate goal is to normalize PTH, really the preferable choice here is B. Again, another important thing to know would be if the patient's on dialysis or not, since that often dictates the decision. However, in the absence of that information, really your choice is going to be targeted towards your end goal of normalizing PTH. So B is really the best answer here. It's a tricky one. But now let's throw in a twist. What if this patient had the same intact parathyroid hormone level, but this was accompanied by a calcium phosphorus product greater than 55, as well as multiple sites of vascular calcification? What's the problem with starting active vitamin D in this patient? Any thoughts? Okay. The issue is that administration of vitamin D is going to further increase calcium and phosphorus absorption, right? IV does this to a lesser extent than PO through the GI tract. However, IV is still going to do it. So the fact that administration of vitamin D is going to increase our calcium and phosphorus levels further is just going to worsen the vascular calcifications in this patient. So really the optimal agent for this hypothetical patient is one that can decrease PTH secretion and at the same time not simultaneously increase calcium and phosphorus. And the agent which does this is cinecalcet. So this is our calcimimetic, and the brand name for cinecalcet is actually derived through its mechanism, so it makes it easy to remember. It's a calcimimetic which increases the sensitivity of calcium-sensing receptors on the parathyroid gland, which is important because it's ultimately these calcium-sensing receptors on the parathyroid gland which increase PTH secretion. So essentially, if we can increase the sensitivity of these receptors through the use of cinecalcet, we're going to have less PTH secretion from the parathyroid gland when we give cinecalcet. And again, standing in contrast to vitamin D, what we're going to do here is instead of increasing calcium and phosphorus, we're going to decrease calcium and phosphorus in addition to decreasing PTH levels. So it's a really good agent for a unique patient population in this case, and for that reason is safe in hypercalcemia and hyperphosphatemia, unlike what we saw before with vitamin D. Cinecalcet comes as 30, 60, and 90 milligram tablets. We start with a dose of 30 milligrams daily, and then titrate every 2 to 4 weeks, ultimately to achieve our goal intact parathyroid hormone levels of 150 to 300 in this patient population. Again, these numbers for intact parathyroid hormone are higher than what they would be in a healthy patient, but this is what we're looking to achieve in this case, 150 to 300. Our side effects predominantly GI, nausea, vomiting, and diarrhea. And the important point to mention here is that you can take cinecalcet with food to help mitigate these GI side effects. And cinecalcet also causes hypocalcemia. So really, we should not be starting this medication in somebody whose serum calcium is less than 8.4 due mostly to concerns that we can induce symptoms of hypocalcemia, such as paresthesias. So safe for someone who's hypercalcemic, not safe for someone who's hypocalcemic. More information about cinecalcet. There are many drug interactions associated with it. It's a strong CYP2D6 inhibitor, and it's a CYP3A4 substrate. In terms of the exam, don't worry about specifics, just know that it's associated with many drug interactions. I'd also like to bring up a study published by Cherteau and colleagues in the Clinical Journal of the American Society of Nephrology in 2006. Essentially, the take-home message of this study was that we had patients who were on supraphysiologic doses of active vitamin D. These patients were crossed over to a cohort in which they were reduced to physiologic doses of active vitamin D in addition to cinecalcet. And what they found by the end of the study was that those who received both cinecalcet and active vitamin D were more likely to achieve goal calcium phosphorus products and goal intact parathyroid hormone levels than those who were on supraphysiologic doses of active vitamin D alone. The take-home message here is not that we need to administer them together, but in select patients, we can actually use these agents synergistically to optimize our treatment and to help us achieve our treatment goals. So something to consider, obviously, is combination therapy, which we'll often see when we get to cinacalcet in these patient populations. However, despite promising numbers, how this translates to overall cardiovascular events and overall mortality is not as clear. Last but not least, I'll introduce patient JR, an 81-year-old female recently diagnosed with CKD-MBD, filling a script for cinacalcet at the first time, and she wants you to counsel her about her new medication. What do you say? Do you say A, cinacalcet has many drug interactions, B, it's safe to use even if she has low calcium and phosphorus levels, C, it should be taken with food to reduce side effects, D, would you say A and C, or E, all of the above? Great job, guys. I think you understand it. So yes, definitely cinacalcet has many drug interactions, given that it's a CYP2D6 inhibitor and CYP3A4 substrate, involves it in a lot of potential pharmacokinetic drug interactions that we need to be aware of. C is correct. Again, we have GI side effects, which we can mitigate if we take it together with food. Where you need to be careful is choice B. So remember that cinacalcet is not safe in the setting of low calcium and phosphorus. It's safe in the setting of high calcium and phosphorus, where vitamin D would be less desirable. In a patient who's hypocalcemic, you would avoid cinacalcet. I think most of you understand that. Last but not least, I just want to conclude with a novel treatment approach we may see take hold in future practice that's currently on the horizon. What this is fibroblast growth factor 23. And what I'll say about this is at this point, mainly what we know about fibroblast growth factors are in the field of oncology, namely with respect to angiogenesis, which is the recruitment of blood vessels to tumors to promote their growth. However, in recent years, what we've seen is implications of fibroblast growth factor 23 in the CKD-MBD patient population. So what I present on this slide is what we know at this point. And what we've seen is that serum FGF23 levels increase with declining renal function in patients with CKD. The effects of this are that this promotes phosphate excretion in the urine to help prevent hyperphosphatemia, which seems like a great thing in these patients, right? Patients with CKD tend to be hyperphosphatemic, given that phosphorus is eliminated by the kidneys. However, elevated FGF23 has also been associated with decreased calcitriol synthesis, treatment-resistant secondary hyperparathyroidism, faster CKD progression, as well as an increase in overall mortality. Therefore, what we know about FGF23 at this point, the bad really seems to outweigh the good with respect to FGF23. Therefore, a potential future treatment goal that we may see in CKD-MBD is inhibition of fibroblast growth factor. And we've actually seen some of these agents take hold in clinical trials to date. Now, essentially what this table is it essentially illustrates a bunch of small molecule inhibitors which have been explored in clinical trials, as well as the fibroblast growth factor receptors that it's been associated to inhibit. And so this has been investigated, and what I said before, namely this has been in oncology, where we're looking at these agents as anti-angiogenics to prevent tumor growth. However, basically what I want you to take away from this slide is just that FGF inhibition seems like a promising treatment strategy, and we may explore it in the future in CKD-MBD patients as our understanding of fibroblast growth factor in CKD-MBD grows. But certainly for the purposes of the exam, don't worry about memorizing which small molecule inhibitor inhibits which fibroblast growth factor receptors. Just remember that this is something we may see in the future. In summary, we utilize a stepwise approach in our CKD-MBD patients. Our first-line approach is dietary phosphorus restriction, but remember that most patients struggle significantly with this in itself. It's very challenging to do. Therefore, in this situation, we'll add phosphate binders, either calcium or non-calcium containing, to help achieve our phosphorus goals. Beyond that, we will begin active vitamin D supplementation to attempt to decrease PTH secretion. And last but not least, we use cinecalcet. And the reason cinecalcet is reserved as last line, again, is because it can cause hypocalcemia, it has many drug interactions. It's also very expensive relative to our other treatment options for CKD and MDD. So for all of those reasons combined, cinecalcet really comes in last pharmacologically. Note that these agents can either be used as monotherapy or synergistically to potentiate their therapeutic effects, as we saw in that study by Chertot. The take-home message here is individualized therapy. So really all of these patients are unique. There's no one-size-fits-all model. It's really just a strategy of analyzing their labs on a daily basis, as well as their physical exam, to try and optimize outcomes based on what we can do pharmacologically. Regardless of which treatment strategy you choose, make sure you monitor calcium, phosphate, and intact parathyroid hormone levels throughout treatment to assess your treatment and see if any adjustments need to be made. And if despite your best efforts you're unable to control these patients with the best of your abilities pharmacologically, then these patients will need a parathyroidectomy, which, as explained earlier, is surgical removal of one or more of the parathyroid glands. And last but not least, novel treatment approaches targeting FGF23 in CKD and MDD patients may be explored in the future. I included this table as a reference to help you study it. Basically what this outlines is it outlines our three main treatment approaches, as well as their effects on our lab parameters of interest in CKD and MDD. And if you can fill this out on your own after studying the lecture, then you definitely have a good grasp on the general concepts I presented today. So I'd recommend using it as a study guide for this lecture. That's all I have for you today. What questions do you have? Yes?
So do you have a dosing for your party?
So you will not need to know specific dosing. Other questions?
You're saying how did not initiate cerebral palsy is is that palsy?
Yes. Always use corrected calcium.
Okay, so the corrected calcium is what the equivalent use.
Yes, absolutely. So again, just remember that really what we're concerned with calcium is the unbound calcium. The calcium that's bound to albumin, not so much of a concern. Other questions? All right, thank you.